So, Dr. Sharp, my question, quick answer, obviously, because there's no time. Um, how are you guys trying to reflect the population that is treated since your medical school enrollment has decreased in terms of the relative representation of the state of Indiana?
That is a good question that I ask my colleagues on numerous accounts. I know that I can control what I can control, and I think about my scope of influence when I do this work. And so there were a lot of things that were tied up into our admission strategies that should not have been, in terms of thinking about how finances are offered, scholarships are offered. And so while I will say our matriculation numbers were actually good, our admission numbers were really good, the matriculation didn't convert over, and that because of certain financial implications at the school. And so we will just continue, I know from my standpoint within my department, to reach out to folks and encourage folks and think about ways to navigate the financial restraints of attending medical school, because that's really going to move the needle in terms of underrepresented population and their ability to attend.
Thank you. You know, talking about the rural population, it's great. But I don't know if that is translating to policymakers, that when we are talking about inclusion and diversity in clinical research, that this is not just a race thing. How do we communicate this?
Yeah, that's a really good question. I just want to mention one thing. Okay, so I am in the Alliance for Clinical Trials. It's a clinical trial cooperative group. And several years ago, we set an accrual goal for minorities, 20%. We are at 43% for cancer control trials and 23% for treatment trials, and that's sustained over years. We have a dashboard that includes all the different populations, including rural and persons across the lifespan, AYA and older. So we're bringing attention to the providers that these are the populations they need to focus on. And for rural populations, it's the same thing. We need to make sure when we talk about inclusiveness, it's all the populations, including rural. So we need to start educating people what inclusion really means.
Maya?
So I actually have a question, unlike what you might think me trying to end the meeting. It's actually for Dr. Sharp. I'm sorry I had to chime on you.
No, it's okay.
But to continue what you were saying earlier, what about folks that, I know that financial is a big consideration. What about folks that are not dealing with those financial implications? How are you guys addressing those folks, especially right now? I know, like in the past, we've seen that you were saying the enrollment, the matriculation numbers are not quite where you want them to be, although you are admitting students. So, what are the strategies to address besides financial?
So some of the strategies are outside of our control, I think, in terms of climate. So for example, we also saw a low number of women interested in attending school here because it has implications for their practice. And so I think it becomes how are we being advocates of the work that we do? And so I'm sure a lot of my colleagues, like today, for example, are protesting for science at the State House as we speak, and thinking about how we can be more policy advocates. I think that's an area that some of us kind of leverage, but not as many, and informing what certain legislation says and doing more research around that and more opinion pieces around that, because we're seeing some severe implications into how just people perceive this environment and whether or not they want to study. And so that's kind of a strategy that we're taking in addition to looking at financial burden and implications there.
And then I'm going to have Dr. Slesh close this meeting. As a PUBA and a wise PUBA, you've heard a lot of the things we've talked about today. You talked about some of the issues with regards to testing. But what words of wisdom and what action plans are you going to impact on us that you think might make a difference?
Well,
You should come here.
fine.
Closing the meeting.
I have a microphone. That's fine. So the word I heard over and over again listening today that I resonated the most with me was intentionality. None of this happens by chance. If we're to eliminate disparities, it's real work. It has to be measured prospectively. We have to agree on what the solutions are, and then we need to implement those solutions. And at every step of the way, it's all about intentionality. And I think that's the big charge for us going forward. I mean, we've now moved into an era, a political era, where we're actually being actively told we're not even supposed to measure these problems. If my patients die because we can't, not even allowed to measure something, that's a sin. I don't know any better word for it. So we have to emphasize, we as a medical community, we as a healthcare community, that our ultimate goal is to make sure that no one dies because they live in the wrong zip code. We have to make sure that everyone has equal opportunity, and that includes financial opportunity to get the care that they need. And that's the challenge that we're going to deal with a long time. But again, intentionality at every single step.
Thank you so much. So intentionality, and we close our meeting, and I hope to see all of you next year, and the date is on the books. Thank you so much, and see you soon.